I won't take up too much more of your time. I want to firstly introduce Stephanie. Stephanie is a PhD candidate at the Deakin University, and she's also a ICU nurse at the Austin. Welcome, Stephanie.
Okay, good afternoon everyone, and thank you to the organising committee for the opportunity to present here today. So in this presentation, I'll be sharing the results of a scoping review on the effect of two-tiered medical emergency team interventions on hospitalised patient outcomes. I'd like to acknowledge and thank my co-authors, Professor Julie Considine, Associate Professor Darryl Jones, Dr. Elizabeth Oldland, and also Professor Judy Curry for their contributions to this work. And we do have a number of affiliations, including Deakin University, Eastern Health, and Austin Health. So as most of you are aware, the pre-medical emergency team tier of rapid response systems, which I'll now refer to throughout the presentation as the pre-MET tier, is a precursor to the MET that is intended to support earlier recognition of and response to deteriorating ward patients in that period before a MET call is required, and this is done using ward-based resources. The pre-MET tier was introduced to many Australian hospitals around the year 2010, and this was in response to concerns that patients who have MET calls have a high in-hospital mortality, and also that MET calls are associated with a range of unintended consequences, such as de-skilling of ward clinicians and a high demand on ICU resources that threatens the sustainability of rapid response systems. So the pre-MET tier has two defining features. First, the criteria for activation are extended compared to the criteria for MET activation. And this means that those physiological abnormalities that are not traditionally classed as severe clinical deterioration will trigger a pre-MET review. Second, the pre-MET review is typically conducted by the patient's admitting team instead of ICU clinicians. Now, it's intended that effective use of the pre-MET tier will prevent the need for MET calls, enable patient care by clinicians who know the patients already and their goals of care, improve ward clinicians' management of deteriorating patients, as well as improve the sustainability of rapid response systems as a whole. However, we don't know whether the addition of the pre-MET tier to rapid response systems is associated with improvements to hospitalised patient outcomes, and though there have been a number of systematic reviews and meta-analyses focused on rapid response systems, none have included studies that evaluated multi-tiered rapid response systems that specifically include a pre-MET tier. So in light of that uncertainty, we decided to conduct a scoping review to summarise the literature examining the effect of rapid response systems that include a pre-MET tier on in-hospital patient outcomes. We developed a detailed review protocol and conducted a scoping review consistent with recommendations in the literature. For those of you who aren't familiar with scoping reviews, these types of reviews are used to map the volume and nature of research to date on a particular topic, particularly those topics that are considered to be emerging and haven't been reviewed previously. They're used to summarise research findings, to identify gaps, and also to ascertain the value of undertaking a systematic review. We chose to conduct a scoping review rather than another type of review because we knew that the pre-MET tier was an emerging area of interest in the research that had not been reviewed or summarised previously. Studies were considered eligible if they involved hospital patients above 18 years of age, patients admitted to an area where the pre-MET tier is utilised, single or multi-parameter rapid response systems, and if they evaluated the effect of the pre-MET tier or the multi-tiered rapid response system that included a pre-MET tier on in-hospital patient outcomes. Studies also had to be published in English in peer-reviewed journals. Studies were excluded if they involved paediatric patients only or presented aggregate adult and paediatric data, patients attending outpatient areas, patients admitted to critical care areas, as these areas have very different escalation processes for clinical deterioration, and we also excluded guidelines and opinion literature. Our search was restricted from January the year 2000 to March 2019, recognising that the first MET paper was published in 1995 and that studies focused on the pre-MET tier were conducted well after the implementation of METs and those early MET publications. We used a three-step process to identify the studies for inclusion. First, we identified keywords and controlled vocabulary through informal searches of Medline Complete and Google Scholar to develop a comprehensive search strategy. Our search terms were also reviewed by a specialist health librarian. Second, we ran our search on 3 electronic databases that included CINAHL, Medline Complete and Embase. And third, we performed forwards and backwards citation searching to locate other eligible papers that were not captured using our search strategy. And some example search terms are included on the bottom of this slide. A single reviewer conducted the search, and then 2 reviewers reviewed all of the titles and abstracts using Rayan, which is an online systematic review screening application. The full texts of studies that were considered potentially eligible were then reviewed to assess whether they met the inclusion criteria. Data extraction was performed using a customised evidence summary table, and we then mapped the results visually according to the type of rapid response system that was evaluated and the in-hospital patient outcomes that were measured. And then the major study findings were synthesised into a descriptive narrative summary. And quality assessments were not performed, as it is not the aim of scoping reviews to appraise research quality. This slide just shows our Prisma diagram. So the combined database searches yielded 290 papers, and that was after the removal of duplicates. 12 additional records were identified through hand searching, therefore 302 titles and abstracts were screened. 25 papers were reviewed in full, and that resulted in 7 studies meeting the criteria for inclusion in our review. Of the 7 studies included in this review, 6 were conducted in Australia and 1 was conducted in the US. Studies were conducted between the year 2010 and 2017, and in all 7 studies, some kind of observational design was used to evaluate the rapid response system. Next slide, please. Thank you. So 4 of the studies were single-site in nature, and 3 were multi-site studies. Of the multi-site studies, 2 involved patients admitted to public hospitals in the state of New South Wales, Australia, in a specific time frame, and those were the studies by Chen and colleagues and Payne and colleagues. And the sample sizes ranged from around 1,500 to over 9 million patient admissions. In terms of the types of rapid response systems that were evaluated in these studies, so in 6 studies, a 2-tiered rapid response system was evaluated, and in 1, this was a 3-tiered rapid response system. This figure on your right maps the types of rapid response systems evaluated in the studies included in this review. In 5 of the studies, a very specific 2-tiered rapid response system, the Between the Flags program, was evaluated. For those of you who are unfamiliar, the Between the Flags program is a multi-dimensional rapid response system that was implemented in all public hospitals across New South Wales from 2010. In the other 2 studies, an early warning system and a modified early warning system was evaluated. The figure on your right shows the various types of in-hospital patient outcomes measured in the studies included in this review. Most commonly, the effect of rapid response systems that included a pre-MET tier was measured in respect to changes in the frequencies of MET calls, in-hospital cardiac arrest rates, as well as various in-hospital mortality measures. For the purposes of this presentation, I'm just going to focus on some of the global findings that relate to these particular outcomes. Of the 6 studies that reported on rates of MET calls, there was a significant increase in MET calls post the implementation of a 2-tiered rapid response system in 5 of those studies. However, the results that relate to the other outcomes were quite mixed. In respect to in-hospital cardiac arrest, in 2 of the studies, rates of in-hospital cardiac arrest reduced, and conversely, in 1 study, there was a significant increase in code blue referrals. In the other 2 studies, there was no change. And finally, in respect to mortality measures, in 2 of the studies, rates of unexpected death, overall in-hospital mortality, and mortality that specifically related to in-hospital cardiac arrest reduced significantly. but in the other 3 studies, there was a significant increase in overall in-hospital mortality. So this scoping review led to the identification of some gaps in the pre-MET literature. First, we identified there was limited published research overall that related to the effect of rapid response systems that include a pre-MET tier on in-hospital patient outcomes, with only 7 studies meeting our inclusion criteria. Importantly, none of the studies that were included in this review were specifically focused on evaluating the pre-MET tier itself. The study aims were predominantly around evaluating the effect of the rapid response system as a whole. We appreciate that the effect of the pre-MET tier on patient outcomes is likely to be quite difficult to isolate, but also contend that it's important to ascertain the value of the pre-MET tier, particularly given these are so widespread throughout Australian hospitals. Second, there were limited patient outcome measures that have been utilised in the pre-MET research. Very few studies are focused on the effect on unplanned ICU admissions or length of stay. And we also have no understanding around how the addition of the pre-MET tier impacts more subjective patient outcome measures such as patient satisfaction or experience. And third, these studies of the Between the Flags program were quite dominant in this review. As I've mentioned, the pre-MET tier is one component of that rapid response system, so it's not really possible to clearly isolate the impact of the pre-MET tier from these studies. There is need for studies of the pre-MET tier from outside of New South Wales. So in the context of a low volume of research and in the absence of a formal quality appraisal, the effect of rapid response systems that include a pre-MET tier is quite unclear. The findings of our review may suggest that the addition of the pre-MET tier is associated with an increase in MET calls. It was predicted that there would be an initial rise in MET calls in those early years post-implementation of the Between the Flags program, and as the number of pre-MET calls increases, we may eventually see a reduction in MET calls consistent with a dose-response relationship. At the moment, it doesn't look like one of the main aims of the pre-MET tier, which was to prevent MET calls, has been achieved, but there are, of course, many possible reasons why rates of MET calls might have increased, including improved patient safety culture and improved implementation of the MET in some centres. I think it's also noteworthy that only 2 studies in this review provided data on rates of pre-MET calls. Clearly, if the pre-MET tier is going to achieve its intentions, it needs to be used effectively. And there is emerging evidence from other studies that the pre-MET tier is not always used effectively by clinicians. So it's not clear, but suboptimal use of the pre-MET tier could be a reason for some of these mixed results that relate to patient outcomes. Further evaluation of patient safety outcomes is clearly very important in this space, but we also argue that it's necessary to learn more about the way in which the pre-MET tier is designed, implemented and used by clinicians so that future studies focused on outcomes reflect an adequate pre-MET dose. So to conclude, through this scoping review, we found that there are few published studies of the effect of rapid response systems that include a pre-MET tier on hospitalised patient outcomes, with none specifically focused on the pre-MET tier itself. Increases in MET calls were evident in some studies. However, further research is required to determine the value of the pre-MET tier to rapid response systems and to patient safety in this area, particularly outside of New South Wales and using a very broad spectrum of in-hospital patient outcome measures. And there's also need for further studies of clinician use of the pre-MET tier, as its success is likely dependent on a dose-response relationship. And thank you very much for your attention.
We'll take questions at the end. I find it more interesting when there's a panel out here to assist with all question taking. And thank you, Stephanie. I just thought South Australia were the only places that got blackouts, but obviously you get some here too. Our next speaker is